And firstly, from my point of view, I hope many of you to whom I've spoken over the years recognise that I am personally committed to the National Health Service. I'm a public servant by background. Nearly all my working life I've been a public servant. I was a civil servant by profession. I made a decision 20-something years ago that to be a civil servant, you know the Yes Minister episodes, which of course we all understand is in fact a documentary, not a work of fiction. I'm somewhat unusual in having been both Bernard in the past and now Jim Hacker now. But of course you do have to make that decision, and I made that decision over 20 years ago that I didn't want necessarily to be implementing or advising other people, but making decisions and standing up for what I believed in. And a very great part of what I believe in is the concept that people in all walks of life in this country are capable of delivering great successes if they are given the freedom and the opportunity to do so. And I have for many years, I hope in my own party, been an advocate that that is indeed especially true where public services are concerned. That locked up in many of our public services is the capacity for enterprise, for creativity, for innovation and for success that has not been sufficiently realised because the people in those public services have not had the freedoms and the opportunity to make that happen. And it is now literally my opportunity now to make those things happen in relation to the National Health Service. But in doing so, I'm very pleased that I'm not doing so in any sense as an isolated example of what we as a government are setting out to do, but right at the centre of a broader process of public service reform, which David was talking about just 10 days ago, anticipating the Public Services Reform White Paper, and indeed, in many respects, implementing, as I know earlier today you were discussing the concepts of a big society, that implementing many of those ideas too, where public services can also be right at the heart of implementing and delivering greater social action, greater community empowerment and greater community responsiveness. So for me, in the National Health Service in particular, I think we can be leaders in creating that new sense of how we can reform public services to deliver a big society and a greater sense of responsiveness to communities and a greater sense of social action, and also within the public services themselves through modernisation to unleash that energy, enterprise and innovation. Now, I don't think in any sense that inhibits the values of the past. I think for the National Health Service, the values of a service that is available to all, that is comprehensive in the service it provides, which is based on people's need and is free to them, not based on payment or their ability to pay. I think all of those values are absolutely at the heart of the National Health Service, and it does not change those one jot. What it does enable us to do, however, is to add much more new values alongside those enduring values. Now, we do face enormous pressures, and I suspect you've already started to discuss some of those. Pressures on costs, an ageing population, lifestyle and behavioural impacts on things like obesity and alcohol abuse, expensive new drugs, technological innovations. I think we have no idea, for example, what the costs or indeed benefits will be from gene-based therapies, from the application of robotics or nanotechnology. And indeed, consumer and public expectations. People expect the latest and the best treatment, and so they should. But unless we dramatically improve the way we do things, I don't think we will be able to respond to those demands and those challenges as I believe we should. Unless we modernise, every year the relative cost of running the health service would go up. Demand would grow, bureaucracy would expand, productivity would continue to fall, and inefficiencies would become more entrenched. I don't think there is an easy option. If there were no white paper, if there were no bill, if there were none of that, actually many of these pressures would still be there, and many of the consequences and the difficulties that we are all grappling with would be exactly the same. I actually think we will be less well equipped to respond to them. That actually the white paper and the bill is about equipping the National Health Service to modernise and to respond to those pressures and to deal with those challenges. So I don't think there's any easy option. Sticking with the status quo, hoping that there would be more money to meet the challenges ahead is a fantasy. Liam Burns said, there is no money left. Fortunately, insofar as there is money left, the National Health Service has done better than others. And a 3% increase in cash on average to primary care trusts in the next financial year is, under all the circumstances, a good and generous settlement. But we need to use it so much better. We need modernisation. We need to do more to reduce the demands on the NHS through a far greater emphasis on public health. And although I'm not planning to talk about it at length today, I do hope that the legislative changes that come in the Health and Social Care Bill, in the transformation of the Public Health Service, the creation of Public Health England, and the empowerment of local authorities to deliver on the wider determinants of health in the longer term, themselves will play an enormous part in that. But in the NHS, we really need to open up the NHS to make it more competitive, more responsive, more transparent, cutting out waste and bureaucracy. And we need a modern and successful NHS to pay healthcare providers for the results they achieve for patients. Back in the 1940s, when the NHS began, a patient might have been a young man with TB or polio, might have been out at Papworth with TB, sitting in hospital for weeks on end, and that might have been the best place. Papworth is a very nice, bright, dry place. It was a good place for him to be. But today, that typical patient is far more likely to be somebody who's very elderly, with multiple conditions, with as many social care needs as healthcare ones. And if the NHS were to keep such a person in hospital for weeks on end, that may not be at all the best place to be. And tragically, as can happen, as Anne Abraham's report demonstrated just the week before last, it can sometimes be the worst place to be. The challenge for the modern NHS is to reflect and meet those needs, those expectations, and frankly, our ambitions for an NHS that is amongst the best in the world in the 21st century. Now, there are many ways in which we aim to do this. We know we want to give patients far more control over their own care, to give them the choice over what happens to them, by whom, as well as where it happens. There should be no decision about me without me. We will publish far more and far more relevant information on the quality of care being delivered by different providers, so that patients and clinicians can see clearly who is providing the best and, if need be, the worst care. We will allow NHS services to be provided by any organisation that can deliver NHS standards of quality at NHS prices. For why on earth should we stand in the way of patients receiving the best care just because it is not an NHS-owned organisation that provides it? If we were to go down that path, we would stop Macmillan Cancer Care providing nursing care to patients. Or if you were coming down here today from central London, and you come down through Putney, and you pass the Royal National Hospital for Neurodisability, and you look at it and you think, and I've been there and met the patients there, for patients there, some patients there who are indeed requiring long-term inpatient support, there isn't anywhere better for them to be. For some, it's virtually the only place for them to be. It is treated as an integral part of the provision of NHS services for some of the most needy patients in the NHS. And it is entirely a charity. NHS buys services for patients there, but it does not own it. And nobody in the NHS, in my view, regards it as anything less than an integral part of the NHS. And that's the kind of relationship with a wider range of providers that I am looking for. So we will give NHS providers the freedom to run themselves as they see fit, not as one particular tier of bureaucracy or another decides that they should. And so I am ambitious that all NHS trusts should be foundation trusts, and that foundation trusts should have the freedoms that they need to deliver the service that they should. Curiously, I'm following in that ambition my Labour predecessors who said that in 2005 and failed to deliver it in 2008 as they intended. And we will empower clinicians to take the lead across all aspects of NHS care. It is challenging, change is difficult, stepping up for leadership can be difficult. But actually, my view is that it is not my job to tell clinicians how to care for patients. They are the experts. They are best placed to make those decisions. They are best placed to design integrated local services in collaboration with their colleagues, whether in primary, secondary, community, or indeed social care. Managers should be there to support and implement decisions that are led by clinical criteria, not the other way round. And to drive all of this, we will need to change the way we pay for NHS services. And it's that last point, payment, that how we pay for things, that I would like to focus on today for the rest of most of what I say. Now, for many people, particularly some in the press, there has been a tendency to focus almost exclusively on the structural changes that we are making, especially those around general practice-led commissioning. But what may actually make the biggest difference to the care that people receive will be how people behave within the system. To support the national focus on outcomes and quality, we need to align incentives. Now, the outcomes framework leads this. And I think it's been really interesting. People often, what people focus on is the thing people disagree about. But actually, where the focus on patients and the focus on outcomes is concerned, there has been immense sense of consensus, agreement, a feeling that we should have done this a long time ago, and it's very important we're doing it now. So the outcomes framework leads this. Commissioners will be accountable for outcomes and for quality. They will contract for services using the new quality standards produced through NICE. The regulator will regulate and inspect against quality criteria, not just process criteria. Information on outcomes will focus health and social care providers on results. And the pricing system should align directly with this. It is vital that what is rewarded is the best care, not just throughput or a simple process target. We have at the moment a commissioning system which too often is about cost and volume and not about quality and outcomes. We need to focus on quality and outcomes. I want every incentive and every reward to align with the single goal of improving outcomes for patients. Better survival rates, a faster, fuller recovery, more prevention, and the effective management of long-term conditions. At the moment, that is too often not the case. We have a system in the NHS which is somewhat misleadingly described as payment by results. Organisations aren't generally paid for results, they are generally paid for activity. They're rewarded for processes and ticking boxes for doing stuff, not necessarily for delivering the best possible patient care. PBR currently pays, in most cases, for procedures done. If what you want is to tick the box on activity, then that's what you get. The more the merrier was the idea. It was not always that merry. Providers got paid with little regard as to the quality of a procedure or the end result for the patient. From the organisation's point of view, there was scant incentive to improve. You also have some quite perverse incentives. If a hospital provides a poor service and discharged a patient only for them to bounce back a few weeks later through A&E, the hospital wasn't penalised for it, it was paid for it. And if it took a preventative approach which makes a reduced length of stay, it would actually, from their point of view, often mean that there was less payment. Take maternity services. Within antenatal care, the more visits or scans a provider can record, the more money they're paid. It can actually be in the best financial interest of a hospital to provide care on a purely reactive basis, dealing with problems as they arise, rather than planning care to prevent them from happening in the first place. The hospital might benefit, but the mother doesn't necessarily. Another example, I remember with Andy, who was president of the Royal College of Radiologists. I remember him taking me through all this. He said they were started a few years ago providing interventional radiological procedures for treating uterine fibroids. But there was no tariff for this. So there they were. They knew that they could provide a service which was more effective, something which was better from the woman's point of view, a less invasive and less traumatic procedure. But the hospital wouldn't have been able to recover the full costs of interventional radiology, whereas they would get paid for surgery and a hysterectomy. Or take cataract operations. Although the NHS Institute and the Royal College of Ophthalmologists guidelines said that best practice would include combining the initial outpatient consultant with a preoperative assessment into a single visit, far more convenient for the patient, and just a single post-operative outpatient appointment, the tariff didn't reflect this. Instead, it would keep paying out for every pre- and post-operative appointment. The focus wasn't providing the best and most convenient care for the patient, but on making things easier for the provider. So the current system is not the right system. By rewarding treatment over prevention and activity over outcomes, patients lose out. That can't be right. So that is why we are changing the tariff, the way we pay for care. I want commissioners of care, be they primary care trusts now, general practice-led commissioning consortia or the NHS commissioning board in the future, genuinely to pay for results, to reward those who improve health outcomes, for the financial incentives to finally catch up with the driver of demand for ever higher standards. For example, the new tariff for haemodialysis rewards services that apply best clinical practice by paying significantly more for dialysis sessions that are delivered through so-called definitive access than for those that are not. This treatment is better for patients because the faster flow rates result in more effective and efficient dialysis, and it is much safer due to a reduced risk of infection. The tariff has been set so that if patients receive their dialysis in this way, the more the provider is paid. So as well as rewarding those who provide the best treatment, it also provides a strong incentive for those who are yet to bring their service in line with best practice to do so. These changes are about getting the right financial system in place to support the very best patient care and to offer greater patient choice and control. As soon as you bring clinicians together from primary, secondary and community care to design a better service, institutional distinctions quickly fall away. Instead, what becomes important is the patient's pathway of care. So instead of a hospital looking at what it does in isolation, clinicians start to look at what is in the best overall interest of the patient and where their services can best fit into that pathway. It helps to move hospitals from being hospital trusts to healthcare trusts, which I know across the country many of the leading hospitals are increasingly thinking of themselves now as healthcare providers, not just hospital service providers. And I want the way we pay for the NHS to support and encourage this. We take the example of maternity again. Current system pays for activity, but paying for a pathway could actually transform maternity services too. Mothers seeing a midwife at the first would discuss their options, of course, home birth, midwife-led services in an obstetric unit. Mothers will be able to discuss their birth plan and what pain relief they may prefer. But whatever a mother-to-be decides, she should be supported every step of the way by a more integrated system of care, because actually we know whatever the decisions or the options may be at the outset, they may not necessarily be the decisions that are made later on. So we need a network service with clear quality standards that helps to achieve the results that a mother is looking for: a healthy baby, healthy mother, and a good birth experience from the first antenatal appointment to the last time she sees a health visitor. And the midwife, therefore, at the outset, should be carrying out an initial risk assessment in which she takes into account all the relevant factors: underlying health problems, obviously age and other issues, previous problems with childbirth, any particular mental health or social care issues. Now, depending on those results and the risk stratification that is derived from that, the provider would receive a fixed amount up front, ideally for the entire maternity pathway, or possibly split into separate payments for antenatal birth and postnatal care. But in any case, based on the potential medical and social needs of the mother. It is then in the interests of the maternity network as a provider to work as proactively as possible with the mother-to-be to plan and manage her care and to prevent the need for any avoidable interventions. The greater the concentration from the beginning on risk assessment and the smooth management of a pregnancy and delivering the best outcomes, the more that resources can be saved by avoiding unnecessary interventions. And that money saved can then be used to improve the quality of maternity services still further. Because money is paid up front, not least, providers will have the funds to invest in the preventative services they can't necessarily afford when they are only paid for things after the event. Now, this sort of quality-based payment also strips out a great deal of bureaucracy. For as long as a provider meets the nice quality standards, it doesn't matter how they do it. There will be no more telling providers how they should schedule their appointments. That level of detail would be left to midwives or obstetricians to decide based on a patient's own personal circumstances. Let me take another example, reflected in our operating framework published in December, of cystic fibrosis. This time based on a year of care pathway. It builds on the work done not by the Department of Health, but by the Cystic Fibrosis Trust. It set out all aspects of the support that an individual would need over the course of 12 months, depending on the severity of their illness. Now, with that sort of payment, it's much easier to build in quality components, the things that should happen. Some patients will have more complex needs, their payment will be higher, but it is all focused on the most clinically appropriate care, whether that is delivered in a home, a GP surgery, or in a hospital. What it drives is integration. What it responds to is the view of a patient that they don't wish to be negotiating a range of different providers and services. They want to see the service as a seamless service that is designed around their year of care and the care needs that they have. If you have a care plan and a care package, you want to see the payment system support the delivery of that care plan. We can also provide a similar incentive for more discrete episodes of care. There are already a number of so-called best practice tariffs, and we will introduce more. 18 in 2011-12, and one, for example, will be for TIAs or mini-strokes. Payment here will be aligned with NICE quality guidelines, so providers can be paid more for delivering a service that meets those standards, less for one that doesn't. That's what price variation should be about in future, is about establishing competition for quality, not competition for price. And in the case of treating a patient with a suspected mini-stroke, the emphasis is on prevention. Things like an immediate specialist referral, identifying those at higher risk, and getting an MRI scan for high-risk patients can do a great deal to offset future risk of stroke. Payments based on the historic average cost of a treatment can't hope to keep up with fast-paced developments in care. Where NICE clinical guidelines support the introduction of a best practice tariff, we don't want to wait for the cost data to catch up. The more we can shift towards payment for outcomes, the more we can create room for innovation to happen. Chance would have synchronicity being what it is. This morning I was at Barts, opening the Barts Cancer Centre, the new cancer centre at Barts, seeing, which some of you will know, a new radiotherapy therapeutic option called CyberKnife, and which is an alternative to surgery, not an addition to surgery in this particular instance. I promise you I did not lead the witness. But when they were showing me how CyberKnife was going to work, they said, we're ready to go. We've been supported charitably to install this, but we know that there are others across the country who would like to go down this path. But they are waiting for the tariff, because there is not a tariff at the moment. Now, if we actually had payment by results, payment for outcomes, we would automatically be in a position where if you have a new therapeutic option, which either delivers greater quality or in this case can deliver not only quality but reduce cost, there is absolutely no impediment to go there straight away. In fact, there is an incentive to go there straight away. So from that point of view, and the same I remember was true on stroke when we were looking at the introduction of thrombolysis for stroke. There was every incentive to do it, but actually every delay occasioned by the lack of a tariff to support it. So if we move to payment for results, real payment for outcomes, we will lead to exactly that kind of innovation. And indeed, as I mentioned earlier, we can do so, and we are doing so this year, in incentivising for more integrated care between hospitals and community by extending payment to reablement and rehabilitation at home following discharge, at the same time making it very clear that if hospitals are responsible for 30 days after discharge and patients come back to the hospital as an emergency admission, they should not normally expect to be paid for that. And that is not a penalty on the hospital, it is understanding that we are in the business of supporting more integrated care and rewarding for that. Now, what I think is at the heart of this is risk stratification and making sure that different levels of risk are reflected in different levels of tariff. So what we need to do is to make sure that the commissioners are encouraged to provide care that is most appropriate for that patient. One good example of that is a new tariff for multi-professional outpatient clinics for patients needing dialysis. You pay more for patients with complex needs to see a multi-professional team, a doctor, a psychologist, a social worker working together. Patients are given more choice and control, and they can move to their chosen treatment pathway much more quickly. The incentive is always there to provide care that is integrated along the care pathway, aimed at delivering the best clinical outcomes, tailored to the individual clinical and social needs of the patient, not on the convenience of the institution. Now, from my point of view, I focus on this because I think there has been, in the debate on what we're setting out to do in modernising the NHS, a focus on structures, but not even sometimes the structures that really matter most. The structure of payment, the structure of incentives matters most. If we have incentives wrong, behaviour will be wrong. If we get incentives right, some of what are, in fact, I know, the natural desire of clinicians to work together across boundaries in order to deliver better care for patients along the whole patient pathway will be supported. That is what I am aiming for us to do. And it's not about competition to deliver reductions in cost. I know Monitor's going to have that job. You know Monitor's going to have that job. There is going to be greater transparency of cost. We are going to have a regulator whose job it is to identify what is the efficient cost of an efficient provider and continue to drive out unacceptable variation in cost. But actually, as I said way back to the NHS Confederation in 2005, we are operating in a social market, in a regulated market, and it will be regulated prices. But the freedoms that we're intending to create, including the freedoms in relation to pricing, are freedoms to deliver precisely the things I've been describing, which is variation to support quality, the ability to use innovation. So fixed prices is not about fixed tariff that fixes the way everybody does everything in the NHS. There is no point my creating greater clinical freedom and leadership amongst commissioners and providers, and at the same time the NHS Commissioning Board having a payment system that tells everybody how they should do things. Way back in 2006, David Cameron, when he and I were launching our shift from targets to outcomes, he said, we want to move from politicians telling the NHS how they should do things to us being clear about what we're trying to achieve, and then let the NHS go about the process of setting out how they do it. That's why a pricing system should not be a straitjacket, but a structure of supportive incentives. And I think it's really important that not least people here who are opinion leaders understand that that is at the heart of this, and encourage new commissioners now to recognise how they can use the payment by results system and the outcomes framework to deliver precisely that. But it is going to be about leadership. I could make these changes, and if leaders do not step up, then things will not happen well. It is going to be about placing more power in the hands of frontline staff, of clinical staff. Changes to the way we pay for NHS services is not just a technical change. It does require people then to start designing clinical services and pathways and innovating in order to make it happen. We will empower providers to innovate. We will reward them for improving the quality and efficiency of the services they provide. We will empower commissioners to influence the services their providers deliver to gain as much value for patients as possible. But of course, with greater power comes greater responsibility. Clinicians within the consortia, providers, will now have to grasp the nettle and lead those organisations. They will need to look at how they operate now and see how they can do so differently in the future. They will need to work with their colleagues across patient pathways to see how they can deliver not just the best hospital care or the best primary care, but the best patient care. Now more than ever, the NHS needs leadership. It may sound odd coming from Secretary of State for Health. People might look at me and say, well, isn't that your job? Well, it might be for now, but it shouldn't be in the future. The NHS does not need, in the future, with a modernised service, to expect a politician to be providing the leadership to the National Health Service. Leadership should come from within the National Health Service. Clinicians designing the best care for patients. Managers working with their clinical colleagues to realise that change better. Local authorities ensuring that local health care joins up with public health and social care to deliver an overall environment that supports better health. And patients with a voice holding local services to account and playing an active and informed role in their own care. I'm glad to see more clinicians day by day are grasping this nettle. Yesterday, when I was with nurse leaders at the Royal College of Nursing, you're here today. Today also, I've announced the third wave of general practice-led Pathfinder Commissioning Consortia, a further 40 consortia taking now the journey to full responsibility for local health services over the next 2 years. Working with providers, I know from talking to many of the commissioning consortia, starting with exactly that question of how do we design clinical services in our community more effectively across the boundaries that used to get in the way in the past. 40 further consortia bring the total across England so far to 177, covering 35 million patients, over 2/3 of the population. The modernisation of the health service is a big shift. It's a power away from me, away from Whitehall, to the front line. Realising creativity and talent for the NHS for the benefit of patients, realising the enterprise and innovation latent within NHS staff, which they have, I know, by the bucket load. NHS health professionals are amongst our brightest and the best. We should treat them as such. Modernising the way we deliver NHS services, and the way we pay for NHS services is giving them a powerful tool as leaders to deliver the service that we want for patients. I know that a modern NHS will be one that delivers those outcomes for patients, outcomes that are truly amongst the best in the world. Thank you very much.